Nice seeing all of you here today. My name is Gerald Major, and I'm a patient of Dr. Inman's. So aren't we lucky to be here today to learn from Dr. Inman, Dr. Haroon, and Laura, who I also know. This is branded Canadian Spondylitis Association because I recently started volunteering for them. So it was around December, I think, where my rheumatologist, Vandana Alawalia in Brampton, introduced me to Michael Mallinson, who you heard speak earlier. And it was since then where, I've said it before, I think, where I got the most laugh was that I've done a cannonball into the healthcare sector, which I've found to be very rewarding. Before that, I worked for Citibank. I ran operations for North America hedge fund services, so I traveled a lot. I had a big job, and it wore me down to the point where I guess it was about 5 years ago that I couldn't work anymore. So I stopped working, and I had a hard time with that, and I was probably a bunch of years late, and I can remember something pretty clearly about Dr. Inman, and it was for a number of years. It was I don't care. I don't know what you're saying. I don't care what you're saying. Just get me to work. And then it became time when I think I went into him and I said, okay, now I care, and take me out of work. So he did just that. So what I'm going to do a little bit is just kind of go through my story. It's probably a story that you've heard before in different variations, and I would argue that we all have the same story, and the story is on struggle. So I think probably most of you know about struggle. Show of hands here, who is affected by AS? Okay, and then another show of hands on the caregivers, please. Okay, God bless you. Let's get into it. This is my body. I've had, this is my illness list. So ankylosing spondylitis. I also got the pleasure of being introduced to psoriatic arthritis. Psoriasis I get. Iritis I actually have right now. I've just started developing this morning. In my left eye, my right eye is continuous for about 6 years. Then you get the depression. It's called secondary depression. I guess it's a comorbidity, right? And then I get the anxiety, not so much right now because I actually care about what I'm talking about. Osteoarthritis, got a little bit of that, and then a splash of osteoporosis, which showed up when I broke my hip falling on my driveway. And then I teeter-totter on sleep apnea. But I hope to answer some of the questions that were going on about exercise and diet through the course of this. So this all started around 14 for me. I started taping my knees playing hockey, and I've got the more peripheral type where it's a lot more in my joints, in my other outside of my back, knock on wood. I'm going to go into my surgeries, have another one on November 29th. I'll be staying just downstairs there in one of the rooms. You'll be able to see me. Dr. Inman visits me every single time I have surgery here, and there's been a few. Both knees replaced, ankle replacement on my right foot, triple fusion on my right foot, toe fusion on my right foot. Broke my hip and they pinned it. They said there's no arthritis there, so I guess we'll wait and see. Had a cataract removed from my eye with the iritis, and several knee scopes prior to this. So most of these surgeries for me, they've happened in the last 6 years. So every single year, the October-November time frame, I go for surgery. I got 2 left. Here's my medications and supplements, I guess, if you want to call it, right? So you go through down here, you see a lot of the ones that we've been hearing about. Dr. Inman and myself actually made an educated switch. I switched from Remicade, you remember this? Switched from Remicade to Humira. I think I heard the term from Dr. Inman one day when I was working, that maybe I'm a non-responder. I mean, my condition was very aggressive for a number of years. So we said, you know what, let's take the opportunity of my first major surgery which was my first knee replacement, to switch my biologics. My thinking back then is that I'm going to be off work for a bit, so I may as well figure a bunch of things out at the same time. That's how much I didn't want to leave work. So I switched to Humira. Lasted about 9 weeks. I thought at the 7-week mark I kind of felt something good. It might have been a little bit of, I guess, some testosterone running maybe, and adrenaline. But I thought it was something, so I stood the course and then lasted 9 weeks. At the 9-week mark, my finger started doing this, and I got flaring iritis in both of my eyes, so that's actually pretty scary. I couldn't see my computer. I couldn't really work. The next call was to Dr. Inman to get my butt back on Remicade. I did that, and I think that was in 2008. I've been on it ever since, and I'm lucky enough to have it working well within me. I think I'm on borrowed time, but we'll figure that out. And I mean, I've got medications that wake me up, that shut me down, that take away the pain, that make me concentrate, that make me not concentrate. I started to become this robot or bionic that needs to have things allow myself to function and work. So these are my symptoms and side effects. I mean, symptoms from the condition or the conditions, and side effects from the medications. So there's a whole bunch there. Some of them that we've talked about: pain, decreased motivation, increased fatigue, itchy skin, red skin, patchy skin, joint pain, muscle pain, range of motion issues, sleep issues, cognitive decline. Anyone ever heard about that? That's when you start to be able to not remember things as clearly as you once did. That's scary. Decreased appetite. Some people it's increased appetite. Increased sleep for me. Some people are decreased sleep. Broken sleep, blurred vision. As I look at this, it's blurred. Increased risk of illness. Range of motion issues with joints, breathing issues, sleep apnea at times, decreased libido, decreased motivation, mood disorders, and I take a pill for dry mouth because I get so much dry mouth for all the other medications that I take. Now, this is actually on purpose, so this is throwing them all together, okay? So this is quite a mess, and we need a team of people to take care of that. I think that's a common theme that you've heard throughout from all the different speakers, is that we need a team to figure things out. You need a team to work on your car. You need a team to do many other things that you do. So why not for your body? And the fact of the matter is, the why not is usually because we're too busy doing things for either other people, other things, working. You need to prioritize. So start to look at yourself and give yourself the attention that it deserves, because this is very confusing. So let's get to what can I control. Become an engaged patient. Become a responsible patient. Take your medications as you're directed. Find the good doctors that you need. You don't like your doctor, fire them. Maybe that's not a popular thing to say right here, but I've got great ones, and I wouldn't be here right now doing this if they weren't great. Support. It takes a team of professionals to figure this out. So occupational therapist, physiotherapist, nutritionist, dietitians. I mean, try to use all the resources that you can find to help. I mean, that's what I've done through the course of my illness, is try to figure out the kind of team that I need for me, keeping in mind that it's very individual. Just like diet, nutrition, and exercise. Someone's asking questions about diet. Well, I have some knowledge in this and some opinion on this, and what it boils down to is everyone's different, everyone's unique, so you got to try to find the thing that works. Financial assistance, there's ways out there. Disability tax credit exists. You should look into that. These are all types of things really that we at the CSA, the Canadian Spondylitis Association, and many other organizations actually provide information on and help. So a little bit of digging, you can find things to help. Nutrition is unique. I said that already. Exercise your way every day. It doesn't need to be in a gym, doesn't need to be monitored, doesn't need to be anything really except the stuff that you enjoy. Get up and do something every day. The way that you're gonna, I think Laura talked about that, the way that you're gonna sustain a level of exercise that you need is by doing something that you enjoy. So for me this year it meant a lot more swimming because my pool was open, and a lot less of the gym. And what I was telling myself every day is if I could get to the gym or if I could get to the pool and do my exercise there, then I don't need to go to the gym that day. So, I mean, now I'm going to be stuck in the gym because it gets cold in Canada. Take care of your mental well-being. When I left work, I fell into probably about a 3.5, 4-year depression. Wasn't fun. But you can get out, and it comes back. I mean, as early as last week, I've had bouts. As early as last month, I've had bouts. I've put off work that was very easy to do, that didn't take me much effort at all, and I've put it off because of my mental state. I've then, I mean, for whatever reason, been feeling better on a specific day, got motivated on that specific day, and was able to do it no problem. Your mental well-being needs attention, so take care of that as well. What have I learned through my, I guess, cannonball of healthcare sector? And what I mean by that is I now sit on the board of directors for the Canadian Spondylitis Association. I teach a pain management workshop with the Arthritis Society, usually monthly. I've started to do some grant reviews for them, and Michael brings me along to most of the conferences and webinars out there so that I can sign up for other things. I mean, that's the way I feel right now. That's not the way I felt 2, 3, 4 years ago. So what I've kind of learned through my journey, and I don't even like to use the word stability. I'm not sure that there's stability in our illness. I mean, the weather affects me, and my sleep affects me, and my stress affects me. That can kind of come at any point in time. So I kind of like the phrase new normal. Find your new normal, understand the limitations within it, and live within those limitations. So when I say give yourself a chance when you wake up every day, this year I've been battling fatigue and energy a lot. I put a lot of work into my physical last year. I'm doing a lot more mental now. And what I found out was I'm waking up every day and I feel like I don't even have a chance. Last year was very hard on me because I went so hard physically in the gym and to try to get better. And I found out that I was deficient in B12 and my testosterone was low. The medication that I take my testosterone, my free testosterone, and use it up. So I've added B12 and testosterone to my cocktail of medications, and they seem to be working. Mental component of chronic illness is, I mean, key, so I think I've addressed that. There's a new talk about a shared service model and patient and support, and this is coming at a very good time because on the other side you'll see something called patient-centered care, and that's a term that's been used by Health Canada lately to say that they're putting the patient first in decisions and education. I mean, what I've seen on the industry in just a short time is that there's a lot more focus on the patient. So take that and turn it into something good. Be aware of comorbidities. For me, they were depression. They've been weight gain at time. And then all the other kind of illnesses. I worry about my organs. I worry about my heart and that type of health. So be careful not to, I mean, assume something may be AS related when it may actually not be. I mean, get to the doctors and make sure you have good doctors. Volunteer work is very rewarding. It's also very therapeutic. I'm finding that out in the last 6 months firsthand. So get involved. Try to get involved with the CSA would be probably the most helpful to most of you, but pay attention to this campaign to cure arthritis that's being done right here at Toronto Western, who Dr. Haroon and Dr. Inman are both part of. That's the research that they do every day to make us better. So take an active interest in that. I think the number, we talked about it earlier, I think Dr. Haroon was saying that 1% of Canadians, in quick internet search, that came out to me to be about 350,000 people across Canada. The Canadian Spondylitis Association hits 1,800 of those. So if you haven't joined, please join. We need your voice, especially in a patient-centered care environment. 90% of people with arthritis do not meet physical activity recommendations. This is actually troubling when I first saw that. So just a figure up there to try to get you motivated. 3,600 drugs on the drug shortage list. I mean, that's just something I learned that I was actually shocked and surprised about. And another thing that's coming that you may have heard about is that 65% of medical marijuana users currently use it for arthritis. So it's something to pay attention to. That's my alarm telling me I'm almost done, so let me... So, I mean, what does this all mean and what should you do? So, if I back up to this mess, this is kind of the stuff that you can't control. So I stopped worrying about it, right? Once I found out that I had the doctors that I needed, I stopped worrying about all this stuff. And then I started looking at the stuff that I could control. So my message to you would be, again, to define your limitations, create a health plan that's a new normal for you. I was an athlete. I ran track and field. I ran long distance and short distance. I did triple jump and long jump and high jump. I can't do that stuff anymore. I know that. I'm okay with it. And we move on. Become an engaged and accountable patient to your health plan. So set your plan up with yourself, communicate it with your doctors, check it out, and remain accountable to it. That helps with your motivation. Let yourself off the hook and live in a new normal. Just because you can't do things that you used to do, be okay with it. Move on. Give yourself a chance to succeed every day. So if you're not having the energy, not feeling well, then address it with their doctors, get it sorted out, and move on. Eat and exercise for success. A lot of fatigue, a lot of my fatigue that I found out was because I was not burning energy in the day, and I wasn't eating because I wasn't, so that's a vicious circle. So everyone's seen the pain circle, which is all the different stresses that can add to pain, and then once you're in the pain cycle, you can't really get out. But what you have to do is kind of intersect it, stop it, and kind of reverse it. So starts with eating well. You eat well, you nourish your body, you'll have energy to burn, then you burn it. Medication, everything has to work better when your body is circulating and moving and burning. I mean, we were built to move. So set yourself up every day for success. Periodically, Laura mentioned this too, periodically reevaluate your plan. So a couple years later, a year later, 6 months later, the question that came up about exercise, I know how you feel. There's probably 4 out of 5 times I go to the gym, I feel that when I feel that a flare is coming on, about 4 out of 5 times the exercise does me well, and one of those times it throws me right into a flare. I mean, exercise for me probably had nothing to do with it, but it's in my head, so I put it out there and I say, okay, 80% of the time I'm going to be better for going to the gym, and I go. The pain thing, I think you get to know it over time. You know your body the best. I've modified my gym routine from when I was young to now to be a lot more stretching. So I'll do high reps, and I stretch it all the way through. There's no more ego at the gym. Those days are long gone. And then set new goals. Once you've reevaluated and see how you're doing, set new goals and continue to move forward. I think that's really the best way that you can do. Remembering that it takes a team for this. So if you're short on knowledge for certain areas, reach out to people. Come join the CSA. Let us help you make things better. I don't want to mention this too much, but this is, Michael also put this up as an AS Health Storylines app. I actually use it right now. It sends me messages every day at about 9:30 to tell me to work out. You can track your mood in here. You can do a lot of things. These apps, for me, I normally run for a period of time to get to know it, along with the calorie counting things. Run it for a period of time so you kind of get to know where you are, and then you don't need it. And then every 6 months, throw your data in there again and kind of track it and use it and reset. But eventually you learn and you retain. You know how much a sweet potato ends up being. And there's, by the way, sweet potatoes, I have someone that I've seen in my infusion clinics that suffers from Crohn's and colitis, and he cut sweet potatoes out and added russet potatoes because of the sugar and because it affected him. I tried the same. I mean, for me, I don't have quite a reaction to sweet potatoes. But lastly but not least, I want to thank a lot of the people that have supported me through my journey, and then end with a quote, Dr. Robert Inman and group here at Toronto Western. My doctor, Vandana Alawalia, who actually introduced me to both Robert Inman and Michael Mallinson. Johnny Lau, who's about to perform the 4th surgery on my right foot. Dr. Rajiv Gandhi, who did my right knee. And Mr. Dr. Alistair Flint, my psychiatrist from Toronto General, who's been instrumental in this as well. And all the Toronto staff, Toronto Western staff that see me as a patient here every year. So coming together is a beginning, keeping together is progress, working together is success. And that was from Henry Ford, but it's very clear to me that it takes a team to do the stuff that I do within illness. Appreciate your time.
Thank you, Gerald. I mean, there's a level of, the docs can talk about the disease. That's one level of reality. When the patients talk about the disease, it is the reality, right? So we learn about this disease from our patients, not from our books. So we're going to take some time now for questions. Dr. Maroon, I guess we can sit here with the microphone.
Okay, we'll start with one directed question straight about genetics. Can AS still be a genetic disease if all patients are not B27 positive? So what other genes could be involved? For example, as I mentioned, 85% of patients have HLA-B27, so we've always wondered what about the 15% who don't have B27. So what we are realizing now with increasing studies is that there are probably a few more other molecules that can behave exactly like B27 is behaving, the mechanisms I showed you. So probably some of the other genes which are present in the particular individual who is B27 negative may be doing exactly the same function that B27 was doing and leading to disease. So still, we believe that it is a genetic disease. We are yet to concretely identify exactly what other players outside B27, but we still believe that other genes are involved in that disease.
It's a question from a patient says she's allergic to aspirin and reacted very badly to naproxen. So this is actually a big issue for our patients with inflammatory bowel disease, because if you happen to have AS and Crohn's disease or colitis, you can't take NSAIDs. So it's a question that really arises a number of times. Gabapentin, which he's using, so gabapentin, drugs like that, and Lyrica or pregabalin, which are used in fibromyalgia or chronic pain situations, are well worth trying. In fact, if you look at that algorithm up there, analgesic, beside the anti-inflammatories and the biologics, pain control is a central goal of what we're all about. And sometimes we can get there with the NSAIDs and the biologics, but sometimes we can't. So drugs like gabapentin, pregabalin or Lyrica. She also asked about cannabinoids. So Gerald mentioned medical marijuana. It's, of course, legal in Canada now. There are certified clinics around the GTA that are certified to distribute. I think our collective experience from, Gerald could speak to this, and you'll see it on the web too, that patients are reporting sometimes improvement in their sleep, they're more relaxed. And the particular, if you're dealing with a professional who knows the ratios of the THC, you can avoid some of the CNS side effects, right? Some patients don't want to wake up groggy and unable to drive. So it's a question of actually having a skilled practitioner address that.
Okay, so there is an interesting question. Most of the research appears to be focused on the HLA-B27 positive form of AS. But patients who have HLA-B27 negative AS seem to have a different track or disease manifestation. Is that true that the pathology in B27 positive and negative patients are different, or is there more effort to study the B27 negative patients? Well, the 85% numbers that I mentioned are from large cohorts. If you specifically look at our cohort at the Toronto Western. And also if you include the patients who are X-ray negative and MRI positive, actually the percentage of B27 prevalence drops. So overall, out of 1,500 patients that we have in our clinic, 30% or 25% to 30% are B27 negative. So it makes quite a significant proportion of patients. And there is a little bit of debate in the literature about whether B27 really is clinically significant once the diagnosis is made. So do B27 positive patients progress at a much faster rate? So if you look at sequential studies, it's not really seen that B27 positive patients are much more likely to fuse. But however, in some of the studies where they have a large number of patients looking at the damage when they come into the clinic, so the baseline damage, it seems to be slightly higher for B27 positive individuals. Another thing which is more common for B27 positive individuals is the iritis attacks. It is much more common for eye inflammation to happen in B27 positive individuals. On the other hand, bowel inflammation seems to be more common in B27 negative individuals. Okay, so it's either way, and it's not really very clear. Same way, psoriatic arthritis is not as strongly associated with B27 as is AS without psoriasis. So there are subtle differences. The problem why it is very difficult to study B27 negative is in large cohorts, even if you put multiple cohorts together, the total number of patients who are B27 negative that being able to accumulate for studies is still small compared to the vast number of B27 positive individuals.
Two questions. So are biosimilars to Humira, are there any downsides? So currently there's a biosimilar to Remicade, that's Inflectra. There'll be a biosimilar to Enbrel on the market this year. It's called Princess, and there'll be as a biosimilar for Humira next year. As best we can determine, the pharmacologists and the biochemists tell us the drugs are metabolized identically. The clinical trials, such as they're done, look very comparable. Just a word on that, for the innovator companies, so the companies that started this all back in the late 1990s, generally required very large numbers of patients in their trials to show both safety and effectiveness. The biosimilars, in a sense, have an easier ride because all they have to show is comparable safety and effectiveness to the established product. So they're coming in late, that's just the point. From a practical point of view, from the point of view of the healthcare system, once the physicians and the patients get more experience with the drugs and are comfortable with their safety and effectiveness, they're going to make a big impact because they're going to change the accessibility of the drugs, both in Canada and around the world. Because the drugs are, as you know, $15,000, $20,000, $25,000 a year. It's very expensive over the course of a disease. So if we're cutting drug costs, so at the moment I would say the landscape at the moment is there to be no significant downside. Is fusion of the spine reversible? As far as we know, not. So basically, once a bony bridge is bridging the two vertebral bodies, that's there to stay. The rare exception is when we turn to our spinal surgeons. So once, at a very, very small percentage of our patients, largely for functional correction, not for pain, go to our spine surgeon to improve their posture. That's a big operation. It should only be done with a very, very experienced team of spine surgeons. But it's really as far as the rheumatologist is concerned, once the bone's laid down, it's there, and nothing but an operation would change it.
Okay, I've moved several papers down. They all ask the same question: is spinal fusion reversible? So you all got the answer. Very closely linked question. I have been on Remicade for the past 6 months without much benefit. Is it still worth continuing to prevent progression of the disease? So very interesting question, and it's still debated whether a particular form of treatment, whether it is a TNF inhibitor or it's IL-17 inhibitor, Cosentyx, and if you take the medication for a sustained period of time, whether it can really stop the disease or not. There are at least a couple of studies that are positive, which suggest that if you start treatment within the first 10 years, preferably within the first 5 years of symptom onset, and you continue the treatment for longer than 4 years. So if you start looking at x-rays at 6-year time point and 8-year time point, you see differences from patients who've been on only anti-inflammatories like Aleve and Advil. The reason is, because it's such a slowly progressive disease, if you look at x-rays within 2 years or 4 years, even without treatment, you don't see that much of a change. So how can you show a difference with treatment? So that's the reason why you need sustained treatment. Now, do we know if you're not getting symptomatically better, whether the fusion is being stopped? I don't think we can make a claim for that right now, because all patients who've been treated so far have been treated for symptomatic reasons, and they continue treatment only if they improve for symptoms. So we don't have information from patients, and in fact, I don't think we'll have any patient who will continue the drug for long periods of time without symptomatic. So we don't have the data to support that at this time.
How do you aim to resolve the gender bias in spondyloarthritis assessment? So the impact, there's significant difference between males and females with AS. And it's one circumstance where, and my wife reminds me every day, there's a real advantage in being a female. But some of the examples, for example, if you compare, I mentioned earlier that we have this umbrella term called axial spondyloarthritis. AS is defined on the presence of diagnostic changes on the x-ray of the spine and the sacroiliac joint. But there are a lot of patients that don't have that. They have the symptoms, but they maybe have a positive MRI. We call that non-radiographic AS, basically, meaning the x-ray is normal, the MRI is positive. Interestingly, in the non-radiographic form, where there's no damage to the AS joints, the sacroiliac joints, that's predominantly female. Whereas advanced AS radiographically is predominantly male. And we know this actually if you look at inflammatory markers in our clinic. The inflammatory markers like CRP and SED-rate tend to be lower in females than males. We gentlemen don't understand why the ladies got this right. But the question is, there's something that modifies the immune response and perhaps down-regulates it a little bit in women with AS. So although inflammation can occur in the sacroiliac joint, there seems to be less predisposition to damage to the joint and less predisposition to new bone formation. It's not understood. Eric Gracie, one of the graduate students on our lab, is actually addressing this question and has found that if you look at different types of T cells, the Th17 cells that are sustaining IL-17, they're expressed at very different levels in males and females. So we actually might, as we move into more targeted treatment, up to now it's been TNFs for everybody. But as we use more selective targets, blocking IL-17, IL-23, we may be able to stratify the patients more accurately. One of the important stratifications may be discriminating males and females and treating them quite differently.
Okay. Could you speak to the effectiveness of Cosentyx, which is the IL-17 blocker, secukinumab, compared to TNF blockers in terms of side effects and adverse events? Yeah. So if you speak in general terms, all treatment modalities are considered equal right now, whether it is the 5 different TNF inhibitors, and if you add Cosentyx with IL-17 into the mix. But in certain circumstances, you may prefer to use one drug over the other. A good example is if somebody has significant inflammatory bowel disease. Etanercept among the TNF inhibitors is not very effective for patients who have significant inflammatory bowel disease, Crohn's colitis. Interestingly, for Cosentyx, there was a trial of Cosentyx in inflammatory bowel disease, and patients who had Crohn's colitis actually worsened on Cosentyx in that particular study. So it's not very effective for treatment of inflammatory bowel disease. So clearly, if you have inflammatory bowel disease, Enbrel and Cosentyx, they are not the drug of choice. Now, if you have significant iritis, again, it's the same issue with etanercept. If you have severe recurrent iritis, etanercept may not be effective. If it is a very infrequent episode, like once a year or once in 2 or 3 years, it's not a major issue at all. Cosentyx, on the other hand, has an advantage in patients who have, for example, multiple sclerosis or similar neurological issues, where Cosentyx doesn't seem to worsen multiple sclerosis and does not seem to cause demyelination of the brain. TNF inhibitors cannot be used if there is associated multiple sclerosis. So there are advantages for different drugs in different situations. If you speak in general terms, all are equally effective.
So this question comes from a 66-year-old male in the room who was diagnosed with AS 48 years ago, and he's not on any medicines, none. Walks 90 minutes every day, although he definitely has new bone formation in his spine. He's got two questions. Is it too late for me to go on medicine? It's not a question so much as too late. It's in terms of spinal fusion, once it's there, it's there. We have a number of patients in our clinic that are on no medications. So if you look roughly at our clinic, about 50 to 55% of patients are on biologics. About 35 to 40% are on non-steroidals alone. But there are a few patients that are on nothing. They're doing terrifically with their exercise program, as Gerald said, about taking control. They exercise rigorously. They keep their diet. And we actually don't know how to predict those patients. They declare themselves because they find out they're managing their disease. From a practical point of view, a patient in their 60s, our current thinking is that probably the bone formation is going to occur primarily in the second, third, and fourth decade. So if a patient is in their 60s, they're exercising well, even though they're stiff, they have minimal back pain, we wouldn't suggest anything. They wouldn't be a candidate for a biologic because they really don't have the pain. And in this particular age group, the risk of the anti-inflammatories like naproxen, indocin, diclofenac rises in the more senior age groups. So we wouldn't want to. We might create more harm than help if we introduce the treatment. But he has a second question, and he said, "What about my family members? Can anything be done?" So that's a lot. First off, in the context of the question, a lot of what drives our research for Dr. Haroon and myself is to find markers that would predict outcomes. Because B27, even in a family, a brother or sister who's B27 positive may or may not develop the disease. Right? That in and of itself is a low predictor. And that influences what we recommend to our patients to have family members checked. So this comes up very commonly amongst our young parents. Should I get my kids checked for B27? Because the last thing I want to do is pass on this disease to my kids. So as Dr. Haroon said, there's the chance of you passing on B27 to each child is about 50%. Because it's on the 6th chromosome, it's just the flip of the coin. But amongst the kids that are B27 positive, no more than 20% would be affected. So the product is 50% times 20 is 10%. To state that another way, 90% on any given child, there's a 90% chance your kids won't have AS. So the odds, they're higher than the normal population, but we don't suggest the kids be tested because we don't want those kids walking around thinking, I'm B27 in their teenage years and someday I'm going to have AS. Because even if they're B27, they probably will never have AS. So we don't want to burden those young people or those kids with a worry and anxiety about that. So that's, okay?
Okay, I've combined two questions on diet. It's a difficult area to discuss. So what is the status of current research on food, and is food a cause for inflammatory conditions? This person says, I have read articles that suggest that gluten significantly impacts inflammation. Are there studies to prove gluten-free diet can have a positive effect on reducing inflammation? Yeah, so diet is a difficult area to discuss as well as to do research, primarily because it's very difficult to control. Maintaining patients on diet, especially for chronic conditions, you need very long-term diaries which are very dependable, and you need a control population who will stick to diets like eating an ice cream daily. Maybe you can do that. But it's very difficult to have a control group and the treatment group for dietary studies. Another major roadblock is also the funding for such studies. Who is interested in doing a dietary intervention study for a chronic disease? To find funding is also another major issue. If you want a one-word answer, is there proof that diet helps arthritis or diet helps ankylosing spondylitis? There is no proof, which is scientific. There is no scientific proof, especially precisely because of the reasons that I mentioned. Now, is there anecdotal evidence? I have 4 or 5 patients who mention that whenever they try to try to eat some form of starch, their arthritis worsens. If they are completely starch-free in the sense that these patients are very, very strict very strict in observing starch-free diet. They're so strict that They even look at the content of the anti-inflammatory pill. They'll not take the pill if there is a starch filling in the pill. They'll not take a salad dressing if there is some carbohydrate in the salad dressing. So they're such strictly, they observe these diets very strictly. And 4 or 5 individuals have mentioned a benefit with this. But I mentioned the total numbers, if we have 1,500 patients. So 5 out of 1,500, is that enough to make a claim that a starch-free diet or gluten-free diet is important? Gluten-free diet is helpful if you have gluten sensitivity. Outside of that scenario, there is no proof that avoiding gluten really is helpful to avoid inflammation.
One question, in the interest of fitness and bone density, I'd like to use weights on machines, like not free weights. Is this likely to increase inflammation or damage? As Laura said, our current thinking is that so repetitive impact loading, so jumping jacks, jogging, or rapid turning like squash, handball, those sports where they're impacting a joint, generally we avoid those. But loading using weights on a machine and those low impact exercises like elliptical, rowing machine, swimming are ideal. The current concept is that exercise still is a good thing. There's been some debate about whether certain professions are actually more associated with AS, interestingly. So usually the question comes the other way. If we have a young patient in their teenage years or going to university, are there any particular professions that they should avoid or emphasize if they've got AS? It's a hard question. Usually their career paths are dictated by other factors. One of our colleagues, Michael Warden at the NIH in the States, looked at this question and actually ranks different types of jobs. Now you can imagine, for example, a car mechanic that's bending forward all day long, or an electrician that's hyperextending all day long is not a good thing. I might say also people that are actually stuck. We have a TTC bus driver in our clinic, and when he's driving his bus hour after hour, he wants to get off, do some stretches, but he's got a bus full of people. It's difficult, right? So depending on what kind of job you've got, it's sometimes, if you're an air traffic controller, you can't walk away from your computer terminal. On the other hand, we have a couple of high school physical fitness teachers, and phys ed teachers, I think, are our happiest group, because they work out with kids when they can do it. They can take ease up when they don't. But a job, obviously, that allows for intermittent stretching, taking a break, getting away from the desk is ideal. But in general, the idea of using weights on machines should be perfectly okay. Loading bone is actually a good thing. Ironically, we know that from the astronauts. When they go into space and they don't load, they come back with significant bone mass reduction. So one of the paradoxes of AS is a bone-forming disease. We see it on the x-rays. But in fact, the patients also get osteoporosis. So it's a balance. And our current feeling is that if we can get the inflammation under control, that's in many ways the best contributor to improving the health, the bone health.
Okay, we have a question on hair is falling out in patches. The dermatologist says it's because of an autoimmune system, and this patient is on Remicade. Have you heard of this, and do you know what is the cause? So the hair fall, there are probably 100 or 200 different causes for hair fall. But in this particular scenario, their hair fall, where I've seen hair fall as a significant issue is when there is concomitant psoriasis. So if you have psoriasis, you can have patches where hair can fall out, and it may not regrow in that area. It is extremely rare. It can happen with Remicade infusions or other TNF inhibitors. So TNF inhibitors can induce an immune response in the body and cause anti-nuclear antibodies or antibodies against oneself in the body. It's very common to find these antibodies, but for that to lead to a systemic disease like systemic lupus or lupus, as we commonly call it, is extremely rare. We have had patients, but it's extremely rare to happen. Maybe a minor manifestation like hair falling off could be related to that, but it's very difficult to, just from this sentence, very difficult to say it is connected or not, because, as I said, there are multiple causes for hair fall.
One question says, speak to the safety of long-term non-steroidals. So non-steroidals are ibuprofen, Motrin, diclofenac, Voltaren, the whole class. And of course, you can get them over the counter, of course. So there are really two concerns that we have with long-term non-steroidal use. One is gastrointestinal. So right across the board, they have the potential for gastritis, gastric irritation, and even peptic ulcer disease and bleeding. So that's a concern. Certainly the patients that have underlying inflammatory bowel disease, we use it extremely cautiously. There are some ways around that, and in terms of the different drugs on the market, for example, a drug like Celebrex is often thought to be a little easier on your stomach. Some have combined, Vimovo, for example, is naproxen combined with the protein pump inhibitor, like omeprazole. And that class of drug often used with NSAIDs, it can actually be effective too. It's a concern we share. There are other risk factors associated with what we call NSAID gastropathy or NSAID irritation. So patients that are smokers, if they drink on a regular basis, if they're taking prednisone, if they've had prior episodes of gastrointestinal bleeding. So there are certain patients that are more at risk for NSAID gastritis. So it's a question of making sure it's an individualized decision. The other is the second concern over time is cardiovascular risk. And so Dr. Hearn's study in the Province of Ontario actually spoke to this. So we recognize now that there are some anti-inflammatory drugs that may actually increase the risk of cardiac events. So one, for example, you might have heard of Vioxx. People in this room might have been on Vioxx a few years ago. It was a terrific anti-inflammatory. It's rofecoxib. But it was clear as it was more widely used in the population, there was a higher incidence of heart attacks. The manufacturer Merck said, we're pulling back. They took it off the market. There's a celecoxib is in that class of drug. It's called a COX-2 inhibitor. The cardiologists tell us that across the anti-inflammatories, there seems to be a bit of a spectrum in terms of cardiac risk. And the consensus at the moment, for example, is naproxen or Aleve probably is the safest drug in terms of cardiac risk factors. So a lot of the choice of the anti-inflammatories should be very individualized with your physician. Whether primary concern is gastric safety, cardiac safety, if there are any other issues going on, for example, kidney or hypertension issues. But many of our patients in the young years, as I mentioned, tolerate their NSAIDs for long periods of time. And in the older age groups, just in general, we use NSAIDs much more cautiously. Is there any correlation between seasonal allergies and AS? Generally not. There'll probably be some people in the room that's seasonal allergies and AS. Anybody? There's one. So two. We've been interested in this because our AS patients seem to have the normal range of hay fever and seasonal rhinitis that normal people get. We've been always interested to see if you're taking Enbrel or Humira, does that get better or worse? The general feeling is that the part of the immune system that has to do with allergy, it's called hypersensitivity, is a different branch of the immune system. Mediated by IgE and eosinophils. It's a different branch of immunity than AS, which seems to have a lot more to do with this HLA molecule. So in general, we don't see seasonal allergy as a big factor there. How does AS affect sexual function? It's a very important question. Laura alluded to that. Gerald actually alluded to it. We've heard this from both our men and women in the clinic. It's an important aspect of your personal life and your married life. I think it's a common experience in our clinic when you're feeling really crummy, you're fatigued, your back is killing you, you're in pain. The last thing you're thinking about is the sexual activity. On the flip side, we actually had a student that looked at sexual function, and the good news there was if the disease can come under control, for example with a biologic, a lot of things improve. Not only your sense of well-being, your energy level, but sexual function often improves in line with that. But it's a complicated scenario. The emotional side of this disease, as Gerald highlighted, affects every aspect of our personal relationships. Let's see, you got a couple here. What role does stress play in developing the disease? Our current feeling is we are working with a neurobiology group here. Some of you actually in the room might have had not MRI of your SI joints, but MRIs of your brain, because our neuroscientists who are trying to understand pain have become very interested in our clinic because you are dealing with pain on a chronic basis. And the neurobiologists here are trying to understand how the brain actually adapts to that. Well, it's pretty clear from their studies, from the functional MRIs, if you break your leg or if you have a tooth abscess, you're going to fire acute pain pathways. The brain adapts very differently if you've had low back pain for 10 years and you can't really remember being free of back pain. So the brain actually has an adaptation to that. And they're teaching us a lot about, actually as rheumatologists, we didn't know we had a brain, but we're learning a lot from these guys. And they're telling us that actually, for example, we have patients where the pain improves with the biologic, but the fatigue doesn't. Well, it turns out there are different parts of the brain that process pain signals and fatigue signals. So we're just kind of learning more about that. And perhaps that'll take us in the direction of more targeted therapies for pain. Recommendations for sleep, again, not in any particular position. Gerald mentioned a couple of examples. Quality of sleep is a very important aspect of the disease. And in fact, some of the more recent trials have included quality of sleep as one of the core measures. Because as you know, if you're waking up at 4 in the morning and have to get up and move into a lazy boy and stretch, by the time you wake up at 6 or 7, you're going to be tired. So sleep is an important contributor to chronic fatigue. Our general experience has been that if we can get on top of the inflammation and the pain, there's improvement. But secondary issues like sleep apnea and other sleeping pills can actually help as well. But nocturnal back pain or night back pain is a really important feature of the disease. One patient said he didn't have a drug plan qualifying for Trillium. So happily, this is a question in Ontario. If you don't have private coverage through work, through your extended benefit plan, through your employer, most of the time we can engage Trillium. There's a deductible, so they review that, but the Ontario Drug Benefit Plan does make a difference. There's a small number of patients, hopefully a very small number of patients in the province that can't access the biologics. We do the best we can. Sometimes we actually approach a company. There are clinical trials going on at all times around the province with newer agents that will take patients in at certainly no cost. But we're fortunate generally in Canada. In this book, when we looked at AS around the world, for example, the chapter of AS in India, it's a huge issue in India about access to biologics. So what do they do over there?
Well, you got to get a job in the central government. You get free drug. Otherwise, it's so difficult. Yeah.
Anyway, any other questions from the floor? Yes. Yeah. Okay. So. Okay.
Okay. Fight again. How important is sleep and one's spiritual life in our fight against inflammation and AS? Excellent question. So there is a branch of immunology known as neuroimmunology or neuroimmunology where the brain's control on inflammation has been studied. It's a very interesting branch of immunology. It is coming up, and I'll give you one example. If a patient with rheumatoid arthritis generally has inflammation and swelling of joints on both sides of the body. If this patient develops stroke, so the connection to the brain on one side is lost, the arthritis on that side completely disappears. Okay, so it is not what as we understand currently. I've talked about the B27 and the immune response of T cells. There is some link with the brain that we have not totally understood currently. And we all know that it is not just physical stress that can cause relapses in arthritis. Emotional stress can cause relapses in arthritis. Emotional stress is an important cause for flares in many different kinds of diseases, including not just ankylosing spondylitis. If you look at rheumatoid arthritis or gout flares even, or non-rheumatic diseases as well. So there is some connection there. So obviously, the less stress you have, and one way, of course, is through spiritual means. If you're a spiritual person, if you have less stress, obviously you'll have better and smooth control of the disease in the vast majority of patients.
Yes.
Do I understand that you have combined anti-tumor necrosis drugs and anti-interleukin drugs in the same patient?
So the question is, what about combining the biologics? So that early on, there were studies looking at the first generation of biologics that were targeting IL-1. That was one of the first ones called Kineret. And they tried some studies, mostly in rheumatoid arthritis, to combine TNF blockers and IL-1 blockers. They quickly backed off because of increased risk of infection. So the challenge for the biologics therapeutics is how do you switch the inflammation down just to the right amount? Because you don't want to switch it off completely. We need our immune systems. So, and similar, so even there have been other trials that may look at a single molecule that blocks IL-17 and TNF, but I think the same concern is appearing in those trials, that it's maybe too much of an immunosuppressive. Yes?
Do you find more complicated eye involvement with AS? I know that there's the typical sort of presentation, but do you see other sort of comorbid eye issues that develop?
Yeah, so you can sort of say it's an advantage compared to the other kinds of arthritis, because usually the eye involvement which you see in AS is anterior uveitis. So it becomes symptomatic very quickly. You get to see the redness, the blurring of vision, the pain, as opposed to some other conditions, for example, juvenile arthritis, where kids less than, say, 10 years of age develop arthritis. A lot of the times you get to know that there is iritis only when it leads to almost partial blindness, because it's behind the lens. You never see the redness. It's not so symptomatic initially. So the vast majority of patients who have ankylosing spondylitis have anterior uveitis. It's very easy to treat. A small proportion of patients do not respond to just local drops. They may need systemic immunosuppression. Some people may need injection into the eye, and some people go on to need biologics for control. But the most common eye condition we see is anterior uveitis.